Hello, everyone. Welcome to the second day of the fourth annual Lymphoma Canada Patient Conference. We're so happy to have you here today. I am Sabina Voher-Miller. I'm a longtime supporter and volunteer of Lymphoma Canada. I'm also the current vice chair of the board at LC. I want to start today by acknowledging the land that I am on, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home to many diverse First Nations, Inuit, and Métis peoples. So with that, I would like to start day 2 with our fantastic panel discussion today on self-advocacy and navigating the healthcare system. Self-advocacy is an important tool to empower patients to learn more about their lymphoma and be actively involved throughout their medical care. This panelist session will provide the audience with information and tools to communicate more effectively with their healthcare teams and better navigate the healthcare system. So with that, I would like to welcome our patient advocate, Charlotte Grad, who has graciously joined us to speak about her experience accessing an innovative therapy that is new to Canada, CAR T-cell therapy. Thank you for joining us today to share your experience with the lymphoma community. We also welcome our nurse advocate, Nanette Cox-Kennett, who is a nurse practitioner for the Bone Marrow Transplant and Hematology Program at the Cross Cancer Institute in Edmonton, Alberta. Nanette has been a registered nurse for greater than 20 years and a nurse practitioner since 2005. Before that, she was a patient educator and nurse educator as well. I'd also like to welcome our pharmacist advocate, Alan Birch. Some of you might remember him from last year's conference on a similar panel. So welcome back, Alan. Alan is a registered pharmacy technician and the oncology drug access facilitator at the North York General Hospital. Alan is also involved in creating online resources for cancer patients and further assists in navigating the healthcare system to obtain cancer medications. And finally, we welcome our hematologist oncologist advocate, Dr. Laurie Sen, who's a medical oncologist at the BC Cancer Agency and a clinical associate professor at the University of British Columbia. Dr. Sen is an expert lymphoma specialist with a thorough understanding of the Canadian healthcare system. She actually is also a member of the Scientific Advisory Board at Lymphoma Canada. Thank you all for being here today. Before we begin, I just want to remind all our attendees that we have a question and answer textbook at the bottom of the screen. If you have any questions along the way, please feel free to put your questions in the text box and we will address them at the end of our panel. We would want this to be an interactive session, so please feel free to ask any questions that you may have to our fantastic panel. Okay, so with that, our first section, next slide, please. Next slide, please, is on effective communication. Studies tell us that patients and loved ones of cancer patients who learn more about their disease and are more actively involved in their medical care have a better quality of life. Some studies even suggest that they may have better outcomes as well. So with that, Dr. Sen, I will start with you. I would like to ask you, why is it important for patients to know their subtype?
Well, it's extremely important for patients to know their subtype. So everybody participating in this call probably has a better understanding of lymphoma than they did before they even heard the word lymphoma. And as you delve into the world of lymphoma, you realize that it's not just one thing. So it's not one kind of cancer, but really a group of cancers that come from our immune system or our lymphoid cells. And because we have a very complicated immune system and there are many different kinds of normal lymphoid cells, it's not surprising that when these cells can become cancerous, that they can become different types of lymphoma. Importantly, the different types of lymphoma can behave very differently and they can respond very differently to different types of treatments. So one of the most important things when somebody gets diagnosed with lymphoma is that they undergo a very careful pathology review so that an exact name is put on their lymphoma, so that guides their doctor in terms of how best to treat that person. So I think it's important for patients to understand their type of lymphoma because that's the first step in understanding the problem that they have, the options that are available to them, and their own expectations.
Great. Follow up with that, Nanette, could you tell us where patients should look for credible information about lymphoma? What should be their go-to sources?
I really encourage everybody to first make sure that they're getting all that accurate information about their subtype, as Dr. Sen mentioned, and also to ask their healthcare provider about other things that might influence some of their disease outcomes and that might affect the choices that are available to them. Things like cytogenetics or mutations that may impact the treatments we want to choose. That information can only come from their care provider unless they have access to their electronic chart, as is available in some provinces, to be able to get that information directly from the source. And as well to ask their provider about staging as well, because that also may impact where we're going next. When it comes to looking for other information, just generically about your disease, sticking with credible websites like Lymphoma Canada or the Leukemia and Lymphoma Society, rather than doing a Google search and getting to the 5th page. So we sort of ask our patients if they are searching for something to be very specific about what they're searching, stick to what comes up on the 1st page. And I even have directed patients to medical resources like if you just Google PubMed, P-U-B-M-E-D, that can actually give you access to medical journals and the scientific studies that some of our decisions are based on. And you can ask your care provider as well for copies of those trials if you're interested.
Excellent. Dr. Sen, do you have anything to add in terms of where patients can get credible information?
Yeah, well, I think, you don't want to skip over your own doctor. So I think patients should be getting most of their information from their own doctor, because that probably is going to be the best source for their particular situation, particularly if they have very detailed questions that have to do with their situation at that point in time. But also, I would just point out that many healthcare facilities have libraries, and they have people to help guide patients through the knowledge acquisition that they need to build up to better understand what they're going through. So in my own healthcare facility, we have a library, we have people willing to help. Even the patient and family counselors can help guide you through some of this. So I would also encourage people to tap into the extra resources that they may not be aware of, because people don't always point that out.
Right, absolutely. So Charlotte, I have 2 questions for you. When you were diagnosed, where did you find valuable information that helped you learn more about your lymphoma? And what did you do to help you feel confident about the decisions that were being made about your diagnosis and treatment?
Frankly, the best resource was my oncologist, Dr. Kuruvilla. My daughter and I had done a lot of research on the internet. We used the resources at the hospital, which were excellent. But it was his team, his fellows, and his healthcare team that basically provided me with the majority of the information. And with time, I learned to feel confident with them and trust their judgment. We had done a lot of research on the internet, but it wasn't always positive. And so the best resource really was my doctor.
Excellent. Which brings me actually to the flip of that question. So where did you find where there are gaps in the information? Where could organizations improve on in terms of providing that information?
Where did I find gaps? Well, truthfully, double hit non-Hodgkin's lymphoma at the time when I was diagnosed, there wasn't a lot of information on it. And CAR-T, the treatment that I ended up having in 2018, wasn't available in Canada at the time. So most of the information I did get about that particular treatment was from the internet, from studies in the States. But having knowledge on the onset was very, very important to me and my family. Knowing that there are other treatments available, which my oncologist always provided. So as I was going through the system and this didn't work and that didn't work, he let me know that there were other things to try going forward.
Great. So patient-clinician relationship, as we see, has a strong foundation, and communication can inform, empower, and build trust both ways for both the patient as well as the physician. So my next question is going to be, I'm going to have you guys take turns. We'll begin with you, Charlotte, and then Nanette and Dr. Sen. If you could tell me, based on your respective experience, what can patients do to improve communication with their healthcare team and get the most out of their appointments?
Coming to appointments with a written list of questions was imperative for me. And if you can get someone to go with you, who writes down the information, so that you can focus on listening and understanding what is discussed, is invaluable. But unfortunately today with COVID, you can't have someone come in with you. So I would suggest either recording it or taking your time and writing it down, because one has to recognize that there is so much information to digest all at once, and you're emotional and you may be exhausted. So it's important to be able to go over things later when you're more relaxed, when you can concentrate and absorb it. And having that available to you is imperative. I also found that it's important to take your time at your appointment and not feel rushed. We are all uncomfortable in this situation. And I think it's important that one leaves that appointment feeling that they've satisfied everything they needed to be addressed. Again, it's really important to know what your diagnosis is. So writing everything down so that later you can digest it, research it if you need, ask your doctor. I always had a phone number available if I needed to ask any questions. And it's, again, and I agree with everybody on the panel, know your lymphoma, your subtype, what stage, what grade, how aggressive it is. What are the treatments what are the options out there? What are the pros and cons? And with that, what are the side effects and how long will the treatment last? What signs and symptoms should I be aware of during the treatment and after? And lastly, what is the prognosis? And what does the current research tell us? So I found it useful and hopeful also to talk to other patients, especially when I was in chemo. I met, for the first time, other patients who had had lymphoma and who had had it several times. And it was the first time I realized that maybe we can live with lymphoma, right? If you can't find a cure, then I can live with this. And that was encouraging. That gave me a lot of hope. There are also guidelines online of questions that you can ask your doctor if you're uncomfortable with it.
That's great.
Yeah.
That's a very comprehensive review. Nanette?
I agree with all of those comments. I do encourage patients to, if it's possible during, we're allowing one visitor at a time with any patient visits. And so that person to be the recorder so that the patient can just absorb the information. We have access to an app that does record the interview if you want a verbal recording so that you can review it later. And then the other thing is that if your healthcare provider is using a bulletin board to maybe go through a little bit more specifics or to explain options, don't be afraid to whip out your phone and take a picture of the bulletin board so that you can refer to it later.
Great. And Dr. Sen?
You know, I think those are all very important points that were made. I guess I would just address the current situation during COVID. And I think that one of the most important things for patients is to rely on their support system. And that's been very important in the doctor visits, because as you know, it's really hard sometimes in the moment to think of the right question. So I fully agree, come in prepared, come in with your questions, but inevitably your doctor will say something and it probably would prompt another question, but you might not think of it in the actual moment. So that's when it's always nice to have that extra set of ears there. You know, one of the things that many of my patients do is they actually use their phone and they'll call somebody during the appointment and somebody will be on the speaker phone with them. So we've got that extra set of ears, even though they're not physically in the room. And I think that's worked out very, very well for people, because it's often that extra person on the phone that will ask, you know, the question that they'll probably come up with when they go back home and they start talking about the details of the appointment. So I would just say, you know, don't be afraid to do that. It gets done regularly in my clinic. And the only other thing I'd mention is that depending on the health facility that you're at, there are other people that you can talk to in the context of your appointment. So we have nurses, we have nutritionists, we have pharmacists, and all of these people are available to speak with you as well. Sometimes people have questions about, some supportive care medicines or natural medicines they want, and the doctors are often not the best source, and maybe not providing the most amount of time to go through these things. So always ask about other healthcare professionals that you can tap into, even if it's not in the moment. These people can be reached on phone consultations or separate appointments, and I think everybody should tap into the wider group of health professionals that are there to help you.
To build up actually on what both Dr. Sen and Nanette you mentioned, could you, either of you or both of you, talk to what are some of the specific questions that patients should be asking at their appointments, or what are some of the questions that are not often asked but should be asked?
I guess my one concern is that at visits, as Charlotte has mentioned, people often get focused on length of remission, but there's also often after you've had treatment, treatment-free interval, which can be important to know. And so you'll have this treatment, and then maybe it may come back, but it might not need treatment right away, depending upon the type of lymphoma or CLL, SLL that you have. And so that's some important information. I don't think patients often ask about that. Another thing when we're talking about the treatment, it's important that we get very specific about how frequent is this medication and how long am I on it? Because there are some medications that are very short intervals, a fixed duration of time, and there's other ones that are continuous. And if it's continuous therapy, how does that impact the rest of my life? Am I still able to work while I'm on this medication, or am I able in COVID alternate times, will I be able to travel, or are there access issues to that medication? Like, for example, here in Alberta, there's some medications we only dispense 30 days at a time. And so that means that it's difficult if you want to be a snowbird and be out of the country for 6 months. And so that's things that you might want to consider in terms of if I choose this option, these are some things that will impact my life. If I choose that options, these are some other things. Of course, side effects are important. And knowing what the best case scenario is. But I also find that sometimes, especially if I have a frail elderly person, I think it's important to ask about worst case scenario, because if I'm being presented with multiple options, to know that this medication choice might be more gentle, maybe a little bit less effective, but a little bit more gentle, and that might lead to better quality of life, not just quantity.
Dr. Sen, do you have anything to add?
No, I think those were all very good points. Obviously, the questions are going to be very relevant to what that person is going through at that point in time. So it's hard to point out a list of questions. But I think, one of the most important things is to understand what the overall goals of care are at any given time. So I think it surprises me sometimes that, patients don't seem to know what to expect with their own lymphoma, whether or not the treatment is aimed to get rid of it for good and to cure it, or whether or not we're trying to suppress it. And I think, when you're faced with a treatment decision, you really need to know what the overall goals and expectations are, because there may be choices, as has been mentioned, and everybody needs to balance that risk and benefit to choose the right option for them to get the most in terms of quality of life. So I think that's a very important concept.
That's a good point. Charlotte, were there anything that came to your mind that haven't been discussed yet in terms of questions?
No, I think everybody's covered everything. It's
excellent.
Yeah.
Dr. Sen, this question comes up very often at LC from our patients. How do I get a second opinion? Will my doctor be offended? How does it work? How do I start the process? Could you speak a little to that?
Mm-hmm. So the first point I'd say is nobody is ever offended about a patient wanting a second opinion. Or that they shouldn't be. So I would not worry about offending your own doctor. I think most importantly, it's really important to to not hide the fact that you're going to get a second opinion. So I think second opinions are understood. You know, everybody realizes that there's not always one treatment choice. And when people are faced with multiple treatment options, they really do want to get different points of view. And so I think getting second opinions can be very important, if only even just to reassure yourself that, you know, you're going down the right path. So I would never be worried about offending your own doctor, but I would encourage you to do it in a way where it's, you know, it's not being hidden, because then it seems a little, you know, sort of covert. So I think your doctor can guide you and even refer you for that second opinion, which makes that very valuable. Usually it does require a referral. So whether or not that referral comes from your own oncologist or your family doctor, generally it would require a referral to be put into another doctor. I would say that for anybody not being seen in a major cancer center, a referral to a major cancer center at some point, I think, is very valuable, because everybody, you know, we'll talk maybe a little bit later about clinical trials, but it's important to tap into kind of the wider range of opportunities that may not be available in a smaller healthcare center, and you want to make sure that you're aware of all options. So I think second opinions can be really important, particularly when it comes to seeing somebody at a major healthcare center that may not become your primary doctor, but they'll, you know, forever be kind of a resource to you if things change and you want to be re-seen or find out about other options.
That's great. Okay, so let's switch gears a little. Next slide, please. Let's talk a little more about understanding cancer drug funding across Canada and access to treatments. So we are fortunate to live in a country with a universal healthcare system. However, what we don't realize is that not all drugs or healthcare services are paid for by our provincial healthcare system. And often we don't realize this until we need to use them. So Lymphoma Canada gets calls and emails from patients very regularly on this topic, and I want to spend some time discussing access and funding. So what I'd like to start with actually is Charlotte. Could you tell us more about your experience with access to the new therapy that you received? How did you and your healthcare team advocate for your access to CAR T therapy here in Canada?
That was basically through Dr. Kuruvilla at PMH at Princess Margaret Hospital. I was diagnosed with in February, approximately February 2017, diffuse large B cell non-Hodgkin's lymphoma. And later I learned that I had two mutations, BMYC and BCL2. One is resistant to chemo and the other one is aggressive. And I had done 2 chemos and 2 trials, and we didn't get the results that we wanted. And my daughter and I had done research on CAR T in 2017. It was still in its trial stages in the States, and it was very expensive. In May of 2018, it came to Canada, and we had talked with Dr. Kuruvilla about it many times, and he actually gave me the option of either going to the States or staying in Canada. And the advantage of the States is, and he would have applied for me and advocated for me through the Ontario government, and I would have gone, but my family's here. My support network is here. And I was the first patient to have CAR T in Canada. So I wasn't sure if they had a multidisciplinary team ready for me, but he promised me that it would be there. And he got the whole thing going forward. I had to do a number of tests. So I had to do pulmonary tests, ECG, biopsies, lumbar puncture, and a whole bunch of tests to qualify and be accepted by the pharmaceutical company. And then a bed became available in September 2018, September 24th. I had my transfusion, and I did go into cytokine storm, and the multidisciplinary team at Mount Sinai Hospital, they rushed me right over, and I don't remember anything for like 4 days. I was gone, but they looked after me. And when I came back, my kids looked after me around the clock at Princess Margaret. I was there for I had another 2 weeks, and then I had to be accessible to the hospital about 45 minutes away. So I stayed downtown. My son put me up, and they looked after me. But it was through Princess Margaret, Dr. Kuruvilla, who advocated for me. I was very fortunate.
Thank you for sharing your experience. It really is a testament to the importance of having that strong healthcare team as well as your support system.
But the research that you do on your own, like we knew about it, right?
Right.
And there wasn't all that much available at the end.
Absolutely.
So I was certainly willing to do it.
Absolutely. Advocacy is excellent.
And I should share that it's 2 years now, and I'm in remission.
Amazing. Dr. Sen, this question is going to be a bit of a complex question, as you and I both know, but in a few lines, could you tell us how, or just give us a general idea of how drugs are approved in Canada?
So, I mean, step one is the drugs need to be approved through Health Canada. So we fortunately have a very safe mechanism for drug approval in Canada. As most people know, that many drugs often get approved in the US first through the Food and Drug Administration or the FDA. So often we'll hear about drugs that are approved elsewhere, and then there's a bit of a gap, but inevitably those companies will file for an approval in Canada. So it actually takes, you know, if a drug has been developed by a company and it has success, they will then file to Health Canada to get that drug approved here in Canada. And Health Canada is a body that reviews all of the information looking at, you know, how effective is this drug, how safe is this drug, and if it meets the threshold, you know, it will inevitably get approved. So step one to getting access to a drug is to get that Health Canada endorsement. But if I have time, and I don't know how quickly you want to go through this, but it's a stepwise process to actually get the drug into a patient's hand or to be able to use the drug in a clinic. And that not only do we need to have Health Canada approval, that just means the drug is available, but most people rely on the healthcare system to provide that drug for them. And funding is what we really need to see to be able to use the drug. And there is a very centralized process now that's been developed to try and make things equitable across the country. So once a drug has Health Canada approval, it then goes to a second body that then puts that drug approval into the context of, you know, the whole treatment landscape and what else is available, and looks at that drug and that indication in terms of cost effectiveness and should we be paying for that drug. And it's only once it kind of goes through that process now and it gets the thumbs up for, you know, not only is this drug safe and potentially effective, but it also makes a lot of sense and would have added value to what we already have. Only if it gets that endorsement would then it be in line to be paid for. So it is a stepwise process, and it can be a bit of a lag and a bit frustrating for patients who know that drugs exist and they're waiting for it to go through that process of approvals.
And the one thing that comes up very often in terms of questions that we receive is understanding that when Health Canada approves a cancer therapy, they have to go through the process, whether it's a new indication or a new line or a type of lymphoma. It's not, you know, when you get an approval, it's for everything. Could you speak a little maybe to clarify this as well?
Correct. So when drugs are approved, you know, they're not approved for everything you can imagine that they could be used for, but basically they're approved based on the evidence that exists for where they're going to be most helpful. So most drug approvals are based on clinical trial data, and the clinical trials have been done in certain types of patients with certain problems at a certain stage in their illness. And, you know, the request is usually to get the drug approved in that scenario where it's proven to have benefit. So, you know, when the drug's approved, it does make it physically available, but most of the time it's only going to be used within the indication that it was approved for, because that's where the evidence lies. Although, you know, having said that, you can, as a physician, use a drug outside of an indication or an approval. And there are, you know, going to be situations where there might be lesser degree of evidence that hasn't earned it a specific indication. And you can always file, you know, in certain areas to see if you can use that drug and get it funded for things that it's not necessarily yet been indicated for. But, you know, that can be a difficult process. And you know, the easiest path is if it's approved in an indication, it gets funded in that indication, then that should make it widely available for most patients.
Great. Okay, so let's switch gears a little. Alan, thank you for patiently waiting. Let's put the spotlight on you.
Sure.
What I would like to ask you, and this is going to be, I guess, several questions in one, but if you could tell us how cancer drugs are paid for in Canada, how does this differ provincially, because we know it's not the same across, and does the government pay for all cancer drugs for everybody? What's the process?
Sure. So that is a big question, but I'll try to summarize just how it all works. So most cancer drugs in Canada are paid for by the provincial government. So each province's Ministry of Health. So for cancer drugs in Ontario, we have two funding bodies. For IV drugs, there's Cancer Care Ontario. And then for any of the take-home drugs, any injections or pills and tablets, they're funded by the Ontario Drug Benefit. So that's the Ontario funding. And then there's similar bodies like that for all of the different provinces. So in BC, there's the BC Cancer Agency. There's the similar system in Alberta. So RAMQ and in Quebec, each province has their own sort of body that funds these drugs. If it's not a provincial body that's funding the medication, about a quarter of medications in Canada are paid through private benefit plans. So these are typically through your employer and their plans through companies like Manulife or Sun Life and Great West Life. And they can also pay for medications. And besides those, besides public or private funding, some patients pay for their medications out of pocket. And sometimes they are provided through a drug manufacturer's patient support programs. So sometimes a manufacturer will provide a medication for free for a certain amount of time or indefinitely for a certain patient. So combined, those are kind of the main ways that drugs are funded in Canada. And there are a lot of differences between the provinces, of course. So in the Western provinces, from BC to Manitoba, you have the cancer agencies like BC Cancer Agency that pay for the IV drugs and the take-home cancer drugs. So if you're getting an IV medication or you're getting a pill that you take at home, they're funded by the cancer agency. Whereas with the Eastern provinces, so Ontario all the way to the Atlantic Ocean, there's a split. So there will be a body that is paying for the IV drugs, and there will be another body from the government that's paying for the take-home cancer drugs. So like I was saying, that in Ontario, that would be Cancer Care Ontario, and then for the take-home drugs, the Ontario Drug Benefit. So that's, and each province has their own agencies. They're all similar, but they all have their own way of funding things. And there's also a difference when they fund drugs. So after a drug has been reviewed by the federal government, you might have a drug that is funded by Cancer Care Ontario right away, and it might take a few months or a few years for it to become funded in Nova Scotia. So there's another review that's done by the province before they add that drug to their formulary, and there can be differences there too. So you might have a drug that is publicly funded in BC, but we're still waiting in Ontario to get access to that one. And your other question about drugs being funded for everybody, there's a patchwork of different bodies that fund different drugs. So combined, most Canadians have drug coverage, but it is definitely different from province to province. In Ontario, it depends on your age. If you're over 65, you have automatic drug coverage through your take-home drugs. If you're under 65, you can apply for coverage. If you're under 25 in Ontario, you have the same coverage as someone over 65. But there's all these different gaps. So it really depends on your age, if you have a private drug plan, and the drug that was prescribed, is it a brand new drug that's funded by the province or not? So it's so many different questions and possibilities that it's best to sit down with a drug access navigator if your hospital has one, or at least with your pharmacist or physician, just to really clarify all the different funding options for you.
Mm-hmm. Yeah, that's very, very comprehensive in the minute that you had to speak about this. But let me, just a couple more follow-up questions on that. Either Alan, yourself, or Dr. Sen, if either of you could talk about some of the things that we get asked very often at LC, is that the drug is approved by Health Canada, but for whatever reason is not being paid for or covered for the patient. And usually this has to do something with access in some form, could be even because of a very, the indication differs, or maybe it's a decision because of P-code or PCPA, something of that sort. Could either of you or both of you talk a little about that and how to explain to Canadians what is some of the barriers in this? Alan, do you want to go first, and then Dr.
Sure.
Sen?
Yeah, no problem. So like Dr. Sen was saying, when a drug gets Health Canada approval, it just means it can be sold in Canada. It doesn't mean that anyone's going to pay for it. There's a gap where if you have a private drug plan, they're going to be reviewing that drug to see if they should pay for it. So even if you have drug coverage through a company like Manulife and the drug has Health Canada approval, they may be reviewing that product before they decide to pay for it, and they may opt not to pay for it. And the same with the provincial plans, they will review the product as well through agencies like P-Coder. It's a federal agency that reviews to see the efficacy and if this drug should be funded. While it's going through that process, there may be no access to it, like no one's going to pay for that product. Your doctor can prescribe it for you, and if you were to pay for it out of pocket, you get it, but the provinces aren't going to pay for it, and your insurance isn't going to pay for it. So there's a lot of times where that's a gap. And of course, as was mentioned, the indication is very important. If you are prescribed a particular drug that's only used upfront as first-line therapy, and that's where the data is, the province may fund that. That sounds like it will meet the provincial criteria. But if you want to use that same drug down the road as a second line of therapy or as a third line of therapy, and that's not where the evidence is, and that's not where the clinical trials were done, the province may say, no, we only fund that as first line therapy, or we only fund that drug with this other drug. You're trying to use it that in a way that doesn't meet criteria. So it might work, and there might be data out there from other countries, for example, that say that this medication will work as a second line of therapy, but the province may say we're still reviewing that, or we don't have the evidence yet to pay for that yet.
Great. Dr. Sen, did you have anything to add to that?
Yeah, no, I would just add that, we are striving to kind of speed up the system and get drugs out there and funded faster. But, the reality is these drugs coming through are very, very expensive, and they're really testing the budget of the healthcare system. So the process that's been put in place has been one to try and create sort of fairness in terms of getting the drugs out that have the most proven benefit, on an equal table. But unfortunately, there are many situations where there might have been less evidence for benefit, and it's just going to fall below the threshold of, what the system can fund. So, there will always be in a situation where, the system's not going to be able to fund everything for everyone. And so, we're hoping to sort of bring out the drugs that, are really obviously going to be most effective in a situation. But in terms of, the biggest, most frustrating gap I find is the timeline. So it takes time for these drugs to get reviewed through the individual committees that then eventually endorse them. And it is important to know that sometimes companies will open up a drug access program, so a free program, while the drug works its way through this sort of tedious system of approvals. And that's something to really ask your doctor about and make sure the doctors are aware of whether or not, when it's going through that sort of long process of approval, if a free source of drug has been opened up by the pharmaceutical companies, because that actually happens quite regularly. And it does happen when everybody expects that the drug is eventually going to get paid for, but not yet. That's when very often you can see these programs opening up so that the drug can get out there earlier.
That's a great point. And actually, speaking on that, and also, Alan, you sort of touched upon this a little as well, but can we talk or tease out some more about take-home cancer drugs and funding for that? And what do patients do when they can't have access to this? So either is it compassionate access, other programs that are available by drug companies to help? Alan, could you speak to that, and Dr. Sen add to that if there's anything that Alan hasn't covered?
Okay. So for take-home cancer drugs, they are funded for a lot of patients, but it's through a patchwork of systems again. So I'm most familiar with Ontario because that's where I work. But for example, if you're over 65 in Ontario, you have coverage through the Ontario Drug Benefit, and that's going to pay for your take-home cancer drugs that meet provincial criteria. So as long as it's being prescribed in a way that the province funds, like the criteria that they've set for the drug, then you're going to get that drug covered. If you're under 25 and you're prescribed that same product, as long as it meets the provincial criteria, and then you're good to go. If you're between 25 and 65 in Ontario though, and you don't have private insurance for your take-home drug, you're going to have to apply to the Trillium drug program, and then they would pay for the drug. But with Trillium, as opposed to the seniors plan and OHIP plus for people under 25, there's a deductible with that. So if you are prescribed an IV therapy, you wouldn't be paying anything for that. The hospital pays for it. But if you're prescribed a take-home drug and you're going through Trillium in Ontario, then you're going to have to pay a deductible. So that's some cost burden associated with the treatment that you wouldn't get with an IV therapy. But that deductible doesn't exist if you're under 25 or over 65. If you are being prescribed a take-home cancer drug that's not provincially funded, then you would hopefully have a private drug plan that may pay for the product. But if you don't have a private drug plan, like Dr. Sen was saying, that's where we tap into these manufacturer patient support programs. And we rely on them quite heavily in my clinic. And in Ontario, I think we're probably the biggest users of these products through these compassionate programs. And for example, I have dozens and dozens of patients who get their drugs through these compassionate programs. It's kind of the only way for a lot of people to get these drugs until they become a provincial benefit. So that gap between Health Canada approval and provincial funding, it's about 2 years now. So for that 2-year gap, that's where these these compassionate programs end up providing a lot of drug for patients. And whenever a new drug comes out, there will typically be a program associated with it. So if you are interested in something that's coming to Canada or has FDA approval, and it's going to be coming to Canada in the next year or two, for example, there might be a program that will open when that comes to Canada, and you might be able to get that compassionately until there's provincial funding.
That's great. Excellent. Dr. Sen, do you have anything to add?
Yeah, so it's hard for me to comment on the dichotomy between IV drugs and oral drugs because I happen to work in one of the provinces where they're treated the same. So, through BC Cancer, where I work, if it's a cancer drug, whether or not it's intravenous or oral, as long as it's funded, we provide it. So that distinction is far less complicated in BC. I will say that, many health centers, so as you can hear, it can be a very complicated process and it can be very different regionally. So I think people need to make sure that they're getting the best information for their local circumstance. And many healthcare facilities now have what's called drug access navigators, because it's even hard for doctors to keep up with all of the potential avenues that there might be. And for scenarios particular to that one person, because people might have private healthcare insurance, they might not, they might have other benefit plans. So we have drug access navigators that we rely on to look at individual patients where we're trying to get a particular drug, to make sure that we're looking at all possible avenues. And if there's a compassionate program, that drug access navigator that works with us will actually help with the application and initiate that for us. So we have created systems like this to try and help people get the drugs they need, and make sure that we're tapping into all of the opportunities.
Mm-hmm. Nanette, is there any differences in Alberta that you can think of?
No, as Alan and Dr. Sen mentioned, the drug access navigator or coordinator is available at most larger cancer centers to help navigate through that. But the smaller centers may be relying on their nurses in clinic. And so a physician may have forwarded on, or a pharmaceutical team may have forwarded on. These are all the papers you need to fill in to try to access this compassionate medication, and that nurse will then magically whip up all the paperwork required. Sometimes there's consent forms that the patient may need to fill in, information that the patient may need to provide about their private insurance in order to qualify for that compassionate access as well, and the nurse may help in that way.
That's great. So we can see that this process is a very intersectional, multidisciplinary team effort. So with that, I want to ask, how does the patient's healthcare team work together to help patients get access to the medications? So Nanette, in terms of your perspective, could you, I know you talked about this briefly, but how do nurses play a role in this? How do they initiate that groundwork that is necessary for access?
I think, as I mentioned, it's about pulling all the right paperwork together, working with the physician and the rest of the pharmaceutical team to make sure that we have everything necessary, so that we don't have to. I don't think, I'm just trying to think. I don't think ever we've applied for compassionate access and been denied, as long as we had all the right forms filled in and we knew what the criteria was in advance. So you pretty much are walking through a process that the outcome. You just have to be coordinated, and that's how we need to just communicate well with each other.
Great. And I think Dr. Sen and Alan, you've both already alluded to how hematologists and oncologists work with drug access navigators like Alan to help patients. But is there anything on this aspect that either of you would like to add?
I'll take that just quickly, Lori, sorry. I would say it's very important that if you do have any questions, to find out if your center has a drug access navigator and to sit down and talk with them. They can help you understand what's available in a funding perspective. The clinical information on your treatment will have to come from your oncologist. But if you're struggling to pay for a medication, if you are thinking about retiring and you're going to lose your private insurance plan, those are the type of discussions you want to have with your drug access navigator, just to make sure that your drug that's being funded through your private insurance, but if you retire, you might lose that. What will happen to me? Can I still stay on my drug? Or are there any compassionate options for a product? I saw something online, can I get that product? So those are the type of questions that you'd want to bring up with your oncologist or hematologist, but also to at least go through that interview process with a drug access navigator, just to make sure that all avenues have been explored for access, but also for coverage, like if you have a copay or deductible with your treatment, because there might be opportunities to have that paid for by the manufacturer. Even though the government's paying for the drug and there's some left over for you to pay for, there might be someone to cover that too.
Great. Dr. Sen?
No, I think that's fairly complete. I don't really have anything else to add.
Excellent. So let's close off this section. Before we take questions, I want to talk a little about clinical trials, because that's another avenue for access. Dr. Sen, could you tell us a little more about how do patients access clinical trials? Are they right for every patient? Speak a little about on this for our community.
Yeah, so I would say that pretty much most cancer clinics across the country, sort of major cancer clinics or academic cancer clinics, will have clinical trials of new drugs available and as a potential opportunity. Certainly not, these can also be available in larger hospitals where they have a fair bit of oncology, but it generally is reserved to the more academic-based larger cancer centers. I think these are so important for people to be aware of and to potentially tap into, because they do present a huge opportunity to patients in that this is the way we get drugs approved. So before a drug is actually approved through Health Canada, it's gone through a testing process through clinical trials to prove its value, to prove its safety. And we've had many outstanding drugs become available in lymphoma where, we've actually been testing it through these clinical trials for years. And I think it was fantastic to hear Charlotte talk about her experience with CAR T-cell therapy, which she accessed at the absolute cutting edge of when it was sort of before it had even become approved anywhere. And that's a great testament to what clinical trials can offer people. Not every clinical trial, is available to all people. I mean, clinical trials have very strict criteria and sort of who can participate based on the type of disease and their sort of personal health state. But those factors are there not to exclude people from clinical trials, just to make sure that they're being done in the safest way possible. So I think that, as a patient, I think everybody should be asking the question, where can I have access to clinical trials? And is there a clinical trial that I should be considering anytime that I have a decision to make in terms of my treatment options?
That's great. Well, that was a very comprehensive and very enlightening panel. Thank you so much for such an amazing discussion on this. I'm going to open it up to questions. We've received quite a few. So our first question is, how important is it to know whether or not your oncologist is very knowledgeable about your diagnosis, especially if it's one of the more rare types? Dr. Sen, would you like to take that one?
Yes, I'm sorry, can you repeat that?
Sure. How important is it to know whether or not your oncologist is knowledgeable about your diagnosis, especially if it's one of the more rare types?
Yeah, so I think everybody has to feel comfortable that their oncologist is knowledgeable in their own situation. Fortunately, I think most oncologists in Canada are remarkably well trained, and I would think that if patients are seeing a medical oncologist, that probably they're aptly qualified. But you should keep in mind that lymphoma is kind of a complicated area of oncology, and there are oncologists who focus more on lymphoma. So I think for people who have the rarer types of lymphoma or things seem a little less straightforward, if you're confident that your doctor sees many patients with lymphoma, then it's likely that they do have kind of the expertise. But the answer is that, the world of cancer is becoming so complicated that I think that there is something to be said for, ensuring that your doctor has the expertise in lymphoma, particularly when it comes to these rarer situations.
So this one was answered by Nanette in chat, but I want to open it up just because I think that it would be it's an important question for the rest of our community to know. If one drug or process, for instance, CAR T, is available in one province, but not in the one you live in, can you travel and get treatment? Nanette, I'll let you answer that one.
I know that we have patients who've been able to travel to access CAR T-cell because right at this minute, the only access that we had to CAR T was in Calgary, and we didn't have access in Edmonton. However, that's recently changed. And now we're just putting our processes in place to make sure that we can deliver that care. We will also be having a clinical trial running up where I'm basically calling it cooking our own stem cells, our own T cells here, instead of using a manufactured product. And so we'll be inviting patients from other provinces to be able to participate in that. However, it's not clear to me, perhaps Dr. Sen can talk to this about this. If I apply for my patient to go to Ontario, that means that the Alberta government has to have agreed to pay for it. And so therefore that approval process or that funding agreement must be in place. Is that correct?
I think it is quite complicated. I think that there is quite a bit of mobility across the country for people to be able to access treatments that aren't readily available in their own province. And so, through the Canada Healthcare Act, you can actually travel to different provinces and get something that is not readily available to you. So there is quite a bit of mobility options, but I think that it likely is something that people need to investigate in terms of the particular thing that they're trying to pursue. In terms of, and I don't want to speak to how the funding gets paid for. It often, my understanding, it often gets paid for by the home province, and it's based on, you know, public access through the Canada Healthcare Act, where you can go to another province and your own province does need to pay for it. But I think this is going a little bit beyond my full capacity of knowledge. For clinical trials, I'll just state that, you know, you can go virtually to any province and access a clinical trial that's available. And clinical trials do have different budgets where a lot of the treatment on the clinical trial is paid for through the trial itself. So I would say that, you know, clinical trials are certainly available to people from around the country, no matter where they're coming from.
And a related question to this, with the central process in place now for drug funding across Canada, does that mean we now have consistency between provinces on what drugs will be available to patients in various stages of treatment?
I'll just comment. So, you know, I think the system that's been created has led to a huge advance into trying to make things equitable across the country, but there's still a lot of discrepancies and inconsistencies. And in part, that's because the funding mechanism is still based on provincial funding. So even though we have these centralized bodies now that, you know, give the thumbs up to a certain drug in a certain situation and claim that it's cost effective and therefore we should all pay for it, each province then needs to look within their own budget and say, you know, can we fit this in and can we pay for it? Fortunately, most of the time when the centralized process is giving a drug the thumbs up, it will eventually get funded in all provinces, but there can be lags and each province can have a slow process to initiating that funding depending on their own internal mechanisms and their overall budget. So I think we're still seeing quite a bit of inconsistencies. Sometimes it's just greater lags in certain provinces.
Alan, did you have anything you wanted to add?
No, I agree with everything Dr. Sen said. I would say that there was sometimes where there's quite long gaps, and there can be certain provinces that will jump right on board. So once a drug gets a positive P code or a recommendation from the federal agency, you might have a province jump on board right away and it's funded, but it can take years for others to fund that same drug. So there can be gaps just depending on the product. So it really varies.
Sounds good. Okay, I think we have time for one last question. This one's a good one. Do oncologists in Canada work virtually with specialists in other countries for advice, collaboration, etc.? Example, Dr. Wang in the US for mantle cell lymphoma is considered a specialist in that specific lymphoma. Dr. Sen, do you want to take that?
Yes, I mean, I think that it's a hugely collaborative world in terms of lymphoma care and trying to make advances in lymphoma care. So particularly those of us that work in academic settings where we do participate in clinical trials and are trying to make advances in the field, I'd say that, you know, we're continuously in contact with international colleagues at the level of the clinical trial work that we do, but also, you know, we continuously tap into this international network in terms of trying to get advice on individual patients and you know, some rare circumstances sometimes come up and you tap into a lot of international people and try to get the best advice from trying to tap into other people's experiences. So I think that happens all the time on a local level where, you know, doctors rely on their immediate community. They might rely on doctors across the country. I routinely get emails from doctors, you know, around the country asking me about particular people and you know, and we do that on an international level as well. So I would say that there's a lot of collaboration and a lot of desire to kind of put the collective knowledge to good use on individual patients for individual patients' benefit.
Absolutely. So the questions that we didn't have time to address today, You can send your questions to info@lymphoma.ca and we will respond to your questions directly. I want to first of all thank all of our panelists, Charlotte, Dr. Sen, Nanette, Alan. Thank you so much for such an exceptional panel with such great discussions, and for sharing your personal feedback and experience to help guide patients on how to continue to self-advocate throughout their lymphoma care, and also to give at least a brief understanding of what the funding and reimbursement structure is in Canada.